Welcome to this session titled Aggregating the Loose Threads, where we dive into a complex case of progressive weakness. As you can see on the screen, we are focusing on a 58-year-old woman presenting with a diagnostic conundrum involving progressive dyspnea and dysphagia. This presentation is unique because it features a hybrid clinical reasoning approach. Notice the roles listed here. We have Dr. Anupam as the clinician, along with several large language models acting as the resident, attending, and consultant. This collaborative effort aims to untangle a web of symptoms that do not immediately point to a single cause. By using these different perspectives, we can simulate the complex decision making process found in modern medical environments. Let us begin by outlining what we hope to achieve during our time together today. Looking at these learning objectives, our discussion will center on two main pillars: clinical reasoning and management priorities. Within clinical reasoning, we want to recognize the pivots that redefine a working diagnosis when dealing with multi system disease. A major focus is evaluating why there might be a discordance between severe clinical weakness and normal laboratory markers, such as a normal creatine kinase. On the right side of the slide, you will see our management priorities. We must prioritize stabilization in cases of cardiogenic shock, especially when it is secondary to severe pulmonary hypertension. Additionally, we will learn to identify critical red flags for respiratory muscle failure and aspiration risk. These goals will guide us as we navigate the complexities of our patient's journey. Starting with the structure of our session, notice the two panels on this slide explaining how our discussion will unfold. On the left, the stages of the case are laid out, moving from the initial presentation of antiphospholipid syndrome through neuromuscular findings and advanced diagnostics to the final tissue diagnosis. On the right, you can see the different perspectives that will chime in. The doctor will reveal objective clinical data in stages, while the resident model offers an initial differential. Finally, the consultant model will provide a critique focusing on safety and potential cognitive biases. This multi layered approach ensures we do not jump to conclusions too early and keeps our reasoning sharp. It allows us to see how different levels of expertise might interpret the same evolving data set. Now, let us look at the first stage of the clinical data. In stage one, we meet our 58-year-old patient who has been struggling with dyspnea and dysphagia for 22 months. Looking at the history and pulmonary function tests on the left, we see a restrictive pattern with a total lung capacity of 63% and a vital capacity of 57%. Most notably, the DLCO is severely reduced at only 26%. Moving to the right panel, her history is significant for extensive acute bilateral pulmonary embolism and right ventricular dilation. She has a confirmed diagnosis of antiphospholipid antibody syndrome, or APS, supported by lupus anticoagulant testing. At this point, the clinical picture seems to be dominated by her vascular history and the resulting pulmonary complications. However, the severity of her symptoms compared to her test results raises some interesting questions. Let us pause for a moment to consider our initial impressions of this clinical frame. As we reach our first audience pause, I want you to consider the questions displayed on the screen. What is the primary diagnostic frame for you right now? Specifically, how do you explain that extremely low DLCO of 26% when compared to the restrictive pulmonary function tests? We also have to consider her medications. Could clozapine be playing a role in her symptoms, perhaps through serositis or cardiomyopathy? Finally, look at the third bullet point regarding her dysphagia. Does this symptom truly fit with her known cardiopulmonary history, or could it represent an entirely separate process? These are the threads we need to start aggregating. Thinking through these possibilities helps us avoid premature closure. Let us see how our resident, consultant, and expert models approach these same questions during this initial stage. On this slide, we see the reasoning at stage one. From our three perspectives, the resident suspects chronic thromboembolic pulmonary hypertension, or CTEPH, or perhaps systemic sclerosis to explain the low DLCO and dysphagia. The consultant, however, critiques the focus on scleroderma as premature. They argue that CTEPS, the leading diagnosis given the prior pulmonary embolism, and APS, while also warning about the potential interaction between clozapine and fluvoxamine. The expert panel on the right provides a primary unifier, CTEPS, due to APS, but suggests that dysphagia is likely a second process. The expert identifies the key pivot as the combination of low DLCO, right ventricular dilation, and prior pulmonary embolism, which necessitates management at a pulmonary hypertension center.
This initial analysis sets a high bar for our diagnostic workup.
Let us look at a key teaching pearl regarding this vascular screening. This teaching pearl highlights the critical nature of the vascular screen. As shown in the left box, when a patient has persistent dyspnea after a pulmonary embolism, particularly with antiphospholipid syndrome, we must be highly suspicious of CTEPF. The combination of a very low DLCO and right ventricular abnormalities is a major red flag. Looking at the imaging sensitivity box on the right, it is important to remember that a VQ scan is the screening test of choice for chronic thromboembolic disease. A CT pulmonary angiogram alone is often not enough to rule this out. This distinction is vital for ensuring we do not miss a treatable cause of pulmonary hypertension. Keeping this in mind, the patient's condition continues to change, and we need to see how her symptoms evolve over the next stage of her care. Moving into stage 2, a new neuromuscular dimension begins to emerge. As you can see under the new symptoms, the patient reports worsening dyspnea and fatigue with even minor activities like brushing her teeth. She is also experiencing liquid dysphagia. Her physical exam is concerning, showing an oxygen saturation of 85% on room air and an elevated JVP. Most importantly, notice the neck flexion weakness at 3 out of 5 and proximal limb weakness between 3 and 4 out of 5. Despite these clear signs of muscle failure, the laboratory work on the right shows a surprising discordance. While the NT-proBNP is significantly elevated at 4,366 picograms per milliliter, her muscle markers are normal. Her creatine kinase is 137 units per liter and aldolase is 6.9 units per liter. This discrepancy between clinical weakness and normal enzymes is a major turning point. Let us reflect on how this neurologic exam shifts our perspective. We have reached another audience. Pause to interpret these normal enzymes. Looking at the questions on the screen, how does the neurologic exam shift your reasoning now? We must consider the significance of liquid-specific dysphagia and that specific neck flexor weakness. A critical question to ask is whether a normal creatine kinase actually rules out inflammatory myopathy. Furthermore, we need to characterize the elevated JVP and BNP in this specific setting. Is the heart failing because of the lungs, or is there something else going on? The presence of neck weakness and liquid-based swallowing issues often points toward the bulbar process that might be separate from her initial vascular diagnosis.
We need to decide if we are looking at one complex disease or two distinct problems.
Let us see how the different reasoning perspectives handle this new confusing information. At stage 2, our models begin to pivot. The resident seen in the first column shifts toward myasthenia gravis, or a myopathy with normal creatine kinase. They also note the potential risk of clozapine toxicity. The consultant corrects the ranking, noting that while myasthenia is possible, the pulmonary hypertension and low DLCO more strongly point towards scleromyositis or immune-mediated necrotizing myopathy. They emphasize that a normal CK does not exclude these conditions. The expert provides a synthesis suggesting a scleromyositis overlap is causing bulbar and respiratory weakness alongside pulmonary hypertension. The expert identifies the liquid dysphagia and neck weakness as a myopathic bulbar fail. This is a crucial distinction that moves us away from just looking at the heart and lungs and focuses our attention on the muscles themselves. To understand why the labs were misleading, we should examine a teaching pearl regarding the normal CK trap. This teaching pearl addresses the common pitfall of relying too heavily on muscle enzymes. As noted on the left, a normal creatine kinase and aldolase do not exclude inflammatory myopathy. This is especially true in overlap syndromes like scleromyositis, where the enzyme elevation may be minimal or absent despite significant clinical weakness. On the right side of the slide, we focus on the bulbar and neck findings. In any patient presenting with liquid dysphagia, dysarthria, and neck flexor weakness, you must prioritize the evaluation of bulbar and respiratory muscle involvement. These symptoms are high-risk indicators for imminent respiratory failure. Recognizing these patterns allows us to look beyond the initial labs and pursue more advanced testing. Next, we will review the results of the advanced laboratory and hemodynamic studies that were performed to clarify this complex picture. In stage 3, we obtain advanced data. The left panel shows the results of a right heart catheterization. The mean pulmonary arterial pressure is 51 millimeters of mercury, and the pulmonary vascular resistance is very high at 16 Wood units. Most critically, the cardiac index is only 1.4 liters per minute per square meter, which signifies cardiogenic shock. Turning to the right panel, the serology and gammopathy results reveal an IgM lambda monoclonal gammopathy. We also see atypical ANXA at a titer of 1 to 320, mildly elevated MPO, and an elevated rheumatoid factor of 130. These findings suggest a systemic autoimmune process and a potentially significant plasma cell dyscrasia. We now have evidence of both severe hemodynamic failure and a monoclonal protein. We must now determine how these disparate findings fit together in a single patient. During this audience pause, we focus on connecting the IgM paraprotein to the rest of the clinical picture. Consider the questions on the screen. How does this IgM lambda gammopathy integrate into the case? Could we be looking at amyloidosis, Boehm syndrome, or even the rare Tempe syndrome? We also need to decide if the atypical ANXA and MPO pattern helps clarify the autoimmune framework or if they are just more loose threads. Most importantly, which is the primary threat right now, the cardiogenic shock or the neuromuscular weakness. Both are life threatening, but they require very different management strategies. The presence of a monoclonal protein often acts as a red herring or a vital clue, and distinguishing between the two is the hallmark of advanced clinical reasoning. Let us see how our reasoning models prioritize these conflicting emergencies. Reasoning at stage 3 shows a divergence in priorities. The resident considers rare systemic vascular diseases like amyloidosis or a variant of POMS syndrome, linking the IgM gammopathy to the vascular issues. The consultant, however, takes a more pragmatic approach, shown in the middle column. They prioritize immediate hemodynamic stability and assessing if the CTEPH is operable, while also demanding an immediate swallow safety evaluation. The expert synthesizes these findings as a dual pathology. On the right, you can see the expert's conclusion. The patient is suffering from both CTEP, which explains the hemodynamic shock, and an autoimmune overlap myopathy, which explains the neuromuscular weakness. This dual catastrophe framework is essential for managing the patient's immediate risk while continuing the diagnostic hunt. Before moving to the neuro workup, let us look at a pearl regarding hemodynamic management. This teaching pearl focuses on managing the hemodynamic emergency. As shown on the left, a cardiac index of 1.4 liters per minute per square meter indicates cardiogenic shock. In the context of severe precapillary pulmonary hypertension, this is a medical emergency that requires specialized ICU care and inotropic support. On the right, we address the paraprotein context. It is vital to remember that monoclonal gammopathies can sometimes be incidental findings. While they require investigation, they should not distract the clinical team from the immediate task of managing acute hemodynamic failure. Stabilizing the heart and lungs must come first, even as we pursue the underlying cause of the muscle weakness. This balance of treating the here and now while investigating the why is a difficult but necessary part of complex care. Now, we will look at the specialized neurological workup that help narrow down the myopathy. Stage 4 brings us to the specialized neuro workup, looking at the electrodiagnosis on the left. Nerve conduction studies and repetitive nerve stimulation were normal, which effectively rules out myasthenia gravis. However, the needle EMG showed fibrillations, positive sharp waves, and early recruitment. These findings are characteristic of an irritable myopathic process. Moving to the right, muscle imaging provides further evidence. An MRI of the proximal leg shows diffuse global muscle atrophy. More importantly, the STIR sequence shows significant muscle edema, visible as a bright signal on the screen. This edema confirms that there is an active, ongoing inflammatory or necrotizing process within the muscle tissue. We now have objective evidence of muscle damage that correlates with her clinical weakness despite the normal enzyme levels. This leads us to our next set of diagnostic questions. At this audience pause, we need to subtype the myopathy based on the irritable EMG and MRI edema. Looking at the questions, what does this combination tell you about the underlying process? If we suspect inflammatory myelitis, Why are the typical markers like Joe 1 and skull 7-0 negative? This is a common point of confusion in complex autoimmune cases. We also face a significant procedural challenge. How do we safely obtain a muscle biopsy in a patient who is in cardiogenic shock with a cardiac index of 1.4? Finally, we must decide if it is appropriate to start high dose steroids empirically before we have a definitive tissue diagnosis. The risk of waiting for a biopsy must be weighed against the risk of the procedure itself. Let us see how our resident, consultant, and expert models navigate these difficult choices. The reasoning at stage 4 confirms we are dealing with two intersecting catastrophes. The resident in the first column favors a scleromyositis overlap, specifically looking at antibodies like PM-scler or POO. The consultant remains cautious, warning about the risks of a biopsy during shock and demanding more serology first. They also raise the possibility of clozapine-induced cardiotoxicity as a confounding factor. The expert shown on the right synthesizes the data into a proven active inflammatory myopathy. They describe the case as two intersecting catastrophes, the hemodynamic failure from CTEP and the neuromuscular failure from the myopathy. At this stage, the team is looking for a unifying diagnosis that can explain why an inflammatory-like myopathy is occurring alongside a monoclonal gammopathy and severe vascular disease. Our next teaching pearl will look at how we localize these muscle issues. This teaching pearl explains how we use EMG and MRI for localization. As you can see on the left, finding fibrillations and positive sharp waves on an EMG is a sign of an irritable myopathy. This tells us the muscle fibers are unstable, which can happen in inflammatory, necrotizing, or toxic processes. On the right, the utility of MRI is highlighted. Stir-positive edema is a powerful tool because it confirms that the muscle insult is active and ongoing. It also acts as a roadmap for the surgical team, helping them identify the highest yield site for a biopsy. By combining these two modalities, we can be much more confident in our diagnosis, even when blood tests are inconclusive. This objective evidence was the final step needed before moving to a definitive tissue diagnosis. Let us look at how we synthesize these findings into two distinct frames. On this slide, we synthesize the findings into two distinct diagnostic frames. On the left is the vascular frame. The problem here is severe precapillary pulmonary hypertension and right ventricular failure, evidenced by the high pulmonary vascular resistance and low cardiac index. This localizes to the pulmonary vasculature, specifically CTEPH. On the right is the neuromuscular frame. The problem is bulbar and proximal muscle weakness, evidenced by liquid dysphagia, neck weakness, and the irritable findings on EMG and MRI. This localizes directly to the muscle. By separating the case into these two frames, we can address the life-threatening aspects of each. However, the ultimate goal is to find the single thread that might connect them. The final stage of our journey provides the definitive answer through a muscle biopsy. We have reached the final results in stage 5. The muscle biopsy of the quadriceps provided the definitive tissue diagnosis. As you can see in the histopathology description on the left, the modified Gomori trichrome stain revealed intracytoplasmic rod-shaped inclusions in 3 micrometer sections. Immunofluorescence confirmed these rods were positive for alpha-actinin 3. These are the classic nemaline rods. Moving to the right, the final diagnosis is sporadic late-onset nemaline myopathy, or SLON, associated with monoclonal gammopathy. Her comorbidity is CTEEPES. Secondary to APS, SLONEM is an incredibly rare and aggressive myopathy that often presents with the exact bulbar and neck weakness we saw in this patient. It is frequently associated with a monoclonal protein, which explains our earlier lab findings. We have finally aggregated the loose threads into a clear, albeit complex, clinical picture. The final reasoning on this slide shows how the pieces finally fit together. The resident notes that SONM-MG elegantly unifies the normal creatine kinase, the bulbar weakness, and the monoclonal gammopathy. They also highlight the significant risk to the diaphragm. The consultant reminds us not to lose sight of the CTEPF, which still requires vital anticoagulation with warfarin and long-term management. The expert identifies the final pivot as the identification of the rods on biopsy. As shown in the right column, SOLON MMG explains the mystery weakness. while CTF explains the shock. This case demonstrates that sometimes a patient really does have two rare life-threatening conditions occurring at once. Managing such a patient requires a high degree of coordination and a broad clinical perspective. Let us look at the integrated management plan for these two conditions. Integrated management for this patient must address both the monoclonal clone and the failing right ventricle. Under clone-directed therapy on the left, the treatment for SLONMG centers on the underlying monoclonal clone. This often involves an autologous stem cell transplant or chemotherapy based on bortezomib. On the right, we see the cardiovascular support required for her CTEF. This involves hemodynamic optimization through procedures like pulmonary thromboendarterectomy or balloon pulmonary angioplasty. Furthermore, she requires lifelong anticoagulation with warfarin due to her antiphospholipid syndrome. This dual-track treatment plan is intense but necessary to address the root causes of her perfect storm. By treating the clone, we hope to improve the muscle weakness, and by treating the vasculature, we stabilize her heart. Let us review the entire diagnostic timeline to see how this case evolved. This diagnostic timeline provides a high-level overview of the case evolution. In stage 1, we were focused on chronic dyspnea and the history of pulmonary embolism, framing the case as CTEEG versus scleroderma. By stage 2, the neck and proximal weakness shifted our frame toward a myitis overlap or myasthenia gravis. Stage 3 brought the critical discovery of cardiogenic shock and the IgM monoclonal gammopathy, leading us to consider systemic paraproteinemia. Finally, in stage 4, the irritable EMG and MRI edema led to the muscle biopsy and the definitive diagnosis of SLONMG.
Seeing the journey laid out like this highlights how each piece of data forced us to refine our diagnostic frame.
It serves as a reminder that clinical reasoning is a dynamic process. Now, let us summarize the key clinical pearls from this challenging case. As we summarize our findings, keep these clinical pearls in mind. First, beware of the normal CK trap. In any adult with neck or bulbar weakness and a normal creatine kinase, you must consider SLONM if a monoclonal gammopathy is present. Clone-directed therapy is the standard of care for these patients and can be life-saving. Second, notice the emphasis on multidisciplinary care on the right. Cases involving a dual catastrophe require seamless coordination between pulmonary hypertension, hematology, and neurology teams. It is easy to get distracted by one mystery, but we must manage all aspects of the patient's illness simultaneously. These takeaways are vital for any clinician encountering complex multi-system disease. We will now conclude with a final synthesis of how these two rare pathologies intersected to create this unique clinical challenge. The patient presented with a perfect storm of two rare pathologies, CTEP from antiphospholipid syndrome causing cardiogenic shock and sporadic late onset Nemaline myopathy, or SLON, driven by an IgM monoclonal gammopathy. Successful management hinged on recognizing the neurologic pivots, specifically the liquid dysphagia and neck weakness, that localized the respiratory restriction to the muscles rather than just the lungs. This case reminds us that a high index of suspicion for paraprotein-related myopathy can unlock a diagnosis that would otherwise remain hidden. When faced with discordant data, such as severe weakness and normal enzymes, we must look deeper into the tissue level. Always maintain a broad differential. Communicate across specialties and listen to what the physical exam is telling you. Screen, counsel, provide.